Good evening. My name is Gail Schwartz. I'm the Vice President of Marketing at LKC Technologies. Thank you for joining us tonight for our objective functional testing for glaucoma, yes, and in minutes. We're excited to have Dr. Justin Schweitzer with us tonight, but let's do a couple of quick housekeeping things. Dr. Schweitzer, can you move the slide real quick? So for those of you who may not be familiar with the GoToWebinar, there's a panel on the right-hand side. There's a red button. If you click that, it'll open your panel. In the control panel, then down near the bottom, you'll see a little arrow with questions. So if you have a question at any time during the presentation, click on that. If you want to keep it open, that might be great. You can type your question in, hit send. We will be monitoring the questions, both myself and Dr. Schweitzer. If we can answer it during the time it comes in, we will. If not, we'll try and hit them all at the end. Everybody will be muted throughout the presentation, so questions should just come through the question box. All right. So let me introduce you to Dr. Justin Schweitzer, OD with Vance Thompson Vision out of South Dakota. Dr. Schweitzer specializes in advanced glaucoma, refractive and surgical clinical care, and anterior segment pathology. In 2012, he pursued his dream to focus on glaucoma, advanced anterior segment surgery care, and pathology. He earned his fellowship in the American Academy of Optometry in 2013, is the optometric externship director at Vance Thompson Vision, and adjunct clinical professor of the Illinois College of Optometry and Kentucky College of Optometry. He regularly lectures on glaucoma, anterior segment pathology, refractive surgical clinical care, and surgical management at state, regional, and national meetings. He currently is the Chief Medical Officer for Modern Optometry. We're excited to have you with us, Dr. Schweitzer, and so I am going to turn it over to you to bring us all up to speed on what's new and exciting in the world of glaucoma management.
Well, thank you so much, Gail, for the kind introduction. I'm just going to kind of back up to the title slide here to kind of set the table of what we're talking about. But really a pleasure and honor to be here. You know, I never take these things for granted. It's always a blessing to be able to do these, whether virtually or live. And it's an opportunity to get together with colleagues and all colleagues that are interested in tonight. It's going to be glaucoma, you know, because specifically what I'm going to be talking tonight is focused on ERG in regards to glaucoma. And I'm going to kind of set the table with mentioning that when I think of glaucoma, I think of like a large puzzle. There's a lot of pieces to that puzzle. When we think about diagnosing glaucoma, we care about the intraocular pressure. We care about central corneal thickness. We care about the OCT and what's happening to the retinal nerve fiber layer and what's happening to the ganglion cell layer. We care about the visual field. We care about family history. We care about corneal hysteresis. So there's a variety of things of that puzzle that we care about. And I really think that ERG is another piece to that puzzle. And what you're going to see tonight, and probably my favorite part of the presentation, is I'm going to share two cases with you that kind of help to piece that puzzle together and really show you how ERG can fit into the management of glaucoma for your patients. And glaucoma can be tough to manage at times. We know that there can be a variety of things that can get into the way of glaucoma management. We may have an OCT that we can't get an accurate measurement on because they have a myopic disc. Or we have patients that can't take a visual field, and that happens all the time. Patients do not do visual fields accurately, even with the changes in visual fields, even with faster visual fields and new technology. It's still a test that at times can be very difficult for patients to do, and it's a very subjective test. We still have to do it. We still have to have it to manage glaucoma. We track progression with it. It's a very important test, but it definitely can create challenges for us. We know that IOP matters in glaucoma, but if we treat solely off IOP, there's plenty of times we're going to overtreat patients, and we're definitely going to undertreat patients as well. And so I really like to think of glaucoma as this puzzle, this artful eye disease, where we take all these different pieces, put them together, and we will make better decisions for our patients. And then we utilize all the different treatment options in our toolbox in order to manage those patients. And so I really want you to have that mindset tonight when we dive into talking about ERG. This alone is not going to diagnose glaucoma, but it can be a very important piece to the puzzle in helping us make decisions and better decisions for our patients. And it may not necessarily be to treat someone, but it may be, hey, instead of bringing that patient back in 9 months, I'm going to bring them back in 3 because there's some risk here that I don't like. There's a lot of red flags that I don't like, and the ERG is part of that as well. Or, boy, everything looks really good here. They have a few risk factors, but boy, the ERG here is a tiebreaker for me, and now I'm going to bring that patient back in 9 months. I don't maybe need to bring them back in 3 to 4 months because things are looking good. You're putting all those puzzle pieces together. So have that mindset as we kind of go through this. A few of the disclosures, I do work with some of the companies that will be talking about some of their technology tonight. Obviously for LKC, which is the RETeval, that's where it comes from, and so I need to disclose that. But really what I want tonight to be is mostly educational. I want this to talk, I want to take you through a couple cases. I want to talk about ERG. I want to talk about the nuances of it, how to read a printout, why it's important when we're managing our patients with glaucoma, and then it can be effective and helpful in our diabetic patients as well, but it's not something that I'm going to touch on a lot tonight. I'm going to touch a little bit on it as well. I love this picture because when you look at this image, you think about ERG. It's been around a long time. You can see here in this particular image that, that would take up a lot of clinic space in most of our practices. And, we don't want an ERG like that in our practices. We're all limited in the space we are. I'm in a huge building. I'm in an MD-OD practice where we have tons of space. But one of the reasons why we love the RETeval is because of the small footprint it takes up, and I'll show you that here in a second. We don't have the space anymore to put an ERG of this size into our practices, and thankfully we don't need to do that anymore as well. A little bit about my practice. I practice in an OD/MD tertiary care practice. Probably 50 to 60% of my day is managing glaucoma. The other 56% is managing anterior segment disease. I work alongside a glaucoma trained ophthalmologist as well as an anterior segment trained ophthalmologist. He spends the majority of his time in the operating room. He's tasked me and my partner OD with managing the clinic. And so myself, my other optometrists that I work alongside of, we run patients through clinic. We're really a tertiary care center. So really, I always say none of the patients that come into my practice are my patients. A lot of times these patients are coming in for a second opinion, or they're coming in because they need surgical care. And then we go ahead and help make those decisions on how we're going to treat those patients. And so quite often when these patients come in, they've already been diagnosed, or they're a patient that's a glaucoma suspect or ocular hypertensive. And my colleague in the community is just seeking another opinion, wanting to know, what should be the next step in this situation. And really ERG has helped a lot of times with some of these patients because they may have already been diagnosed, but the question is, are they progressing? And I'll show you a case here in a little bit that ERG can help with that. Or this is a glaucoma suspect. What do you think the next step should be? And I build that risk profile, and ERG can be a piece of that as well. And you'll see that here in a little bit when we get into that. So when we think of electroretinography or ERG, it's really measuring the various electrical responses throughout the retina. And we're all very comfortable with the different layers of the retina. But specifically what ERG is looking at is it's looking at the photoreceptor layers, so the rods and cones. It's looking at the inner retinal layers, the bipolar, which specifically in diabetes is what we care about. So when you think of ERG and diabetes, you care about those bipolar cells, and that's really part of the ERG piece, which we'll touch on at the end here. But for tonight's discussion, we're going to be talking about glaucoma, and that's the ganglion cell layer. In review, what is the ganglion cell layer? Remember, it's at its most in the macular region. When we think of glaucoma at its heart, what is it? It's damage to the ganglion cells or the retinal ganglion cells. We have a lot of great technology that's measuring the retinal ganglion cells. We have our OCTs. Our OCTs are measuring the retinal nerve fiber layer. The retinal nerve fiber layer is the ganglion cell axons. We have the ganglion cell layer, which a lot of our OCTs will measure as well. I think in order to manage glaucoma in this day and age, we need to be able to measure the ganglion cell layer, and that's the body of the ganglion cells. That's most plentiful again in the macular region. And then we have the interplexiform layer as well, which is the dendrites of the ganglion cell layer. And so we take that into account when we're measuring patients with OCT. The beauty of ERG is it looks at two different things. It looks at implicit time and it looks at amplitude. And I'll get into that here in a second. But the beauty of this is we're looking at the layer of cells that are damaged in glaucoma at the heart of the disease. What's damaged? It's really the ganglion cells or the retinal ganglion cell layer of the ganglion cells. So this is just an image kind of breaking down the different waves or the different parts of the waveform that the ERG is measuring. And when we think about the ERG, I'm going to kind of put some arrows here for you. Light comes into the eye, it stimulates the retina. There we go. And now I got my arrows, and really it's producing a signal. You're having an A wave here. You see the B wave, and the B wave is looking at the bipolar cell function. Really the cells that, as I mentioned earlier, are very important for our diabetic patients. And again, I will touch on that even though we're focused on glaucoma. For tonight's sake, when we look at some of the printouts that come off the RETeval, we're going to be really looking at the photopic negative response. That's the function of the innermost retinal layer, the retinal ganglion cells, which we just reviewed a second ago and how that sets up. That signal then goes to the optic nerve head, which then goes obviously to the brain, so on and so forth. So this is really the printout. This is really the waveform, what you're looking at when you're thinking about an ERG. And again, the PhNR, that's the key piece for glaucoma. The B wave or the bipolar cell function, the key piece for diabetics. So let me talk a little bit about the RETeval, which is the full ERG suite, which is in one device. You can see already when you look at it here, it's a very small device. It's not going to take up a big footprint in your practice. It's something that has been really nice in our practice. It's handheld, it's compatible, it's very portable. It's easy for my technicians to use. And I'll tell you, your technicians will talk about it. They'll comment how easy it is to use it. It's not mydriatic, meaning you don't have to dilate patients to utilize it. Can you do it when they're dilated? You can, but it doesn't need to be done in a dilated situation. And so I found it nice to be able to do it in a variety of situations. There's times, well, I've gotten through my whole glaucoma workup, and in my practice, my patient's already dilated a lot of times when I get into the exam room and they're already dilated. I can still order this particular ERG, have my technician go in and do it, and it's done in a few minutes. It's a very quick test, bilateral. You can have both eyes done in 2 to 3 minutes. So a very, very fast test. It does have these center stripped electrodes, which I'll show you an image of here in a second. And it is important to place those in the correct spot. You'll teach your technicians how to do that. I mentioned how quick it is. Very simple interface. It does have normative database and a color-coded report, which I'm going to show you a bunch of those here tonight. It does easily integrate into the practice workflow. And I think that's a key piece to this particular technology. The patient does not need to leave your exam room. Depending on how your clinics are set up, I work out of 10 different lanes essentially. When I order it, we have this docked outside in our what we call off stage or our galley, and our technicians will just come and grab it. They'll come into the room, they'll perform a test, they'll leave, they'll download the printout for me, and I have it in front of me to go discuss it with the patient. I love that because they don't have to go to a separate room to have the text done. A lot of times with our visual field machines, they have to go to a separate room to have that done. An OCT, they have to go to a separate room. Now we have VR headsets for visual fields. RETeval to me fits into that group because it's very portable, easy to take. If you're in a multi-clinic practice, meaning your clinic, you travel to different clinics, this is a very portable thing that you can take with you to those types of locations if you don't want to purchase or have more than one of these. The other nice thing about this, and I'm going to show you a case of this here in a little bit, is it works through media opacities. Many times what can be very challenging in my practice, for example, is I'll get a patient that comes in where they'll have a cataract. I'm in a cataract practice, but they also have glaucoma. A lot of these patients come with cataracts and glaucoma, or they're ocular hypertensive, or they're a glaucoma suspect. And I'm trying to figure out, all right, do they have glaucoma? Do we need to do a MIGS procedure? What's our next step? Our OCT maybe isn't as accurate as it should be. They can't take an accurate visual field because it's a dense media opacity. You have an ERG that can get through there and give you some objective data because it's not subjective to help in your decision making. And like I mentioned, I'll give you a case here in a little bit that kind of drives home that particular point. Here's what it looks like on the docking station. So you can see the small footprint. You can see actually the printout on the actual image here, but you'll just download this to your EHR or to one of your computers, and you'll be able to see a nice printout that I'll show you here in a little bit. You get an image here of the sensor strips. You can see what the patient sees. You can see also there's a small eye cup that just goes right over the top of the eye, and then the patient has a fixation light that they'll look at as well. So really when we look at this, we think about glaucoma, we think about structure and function. And we know we want to try to keep patients as often as possible on the left side of this. We want to keep them in that functional stress or catch it early on in the disease process, which isn't always easy to do. Our whole goal is try not to let them get to the point where they have vision loss or they have a visual field defect. We can't do that all the time. We all know that, but we do have good technologies, OCT, ERG. We have our eyes when we can look at the optic nerve head, where we can detect these things a little bit earlier in the disease process. The beauty of ERG is it looks at functional stress. And in a little bit, we're going to talk, it's actually coming up very shortly, implicit times. Implicit times are really looking at the functional stress on the retinal ganglion cells. And that's showing functional stress. And if we can catch it early, that doesn't mean we'll necessarily treat these patients, but we'll at least keep a closer watch on them. We may bring them back a little quicker than we normally would. So again, we're looking at that photopic negative response, and that's what we're going to look at in the printout here in a little bit. You can see a study here that was published in 2022 in Clinical Ophthalmology, so a very new study that actually correlated very well with our standard automated perimetry and OCT as being parameters in assessing glaucoma. And can we catch this disease process a bit earlier? Maybe not necessarily treat right away, but keep a more watchful eye on our patients that have earlier functional stress to try to prevent them from going to that structural damage. I love these pictures, and this is from Dr. Simbor at his practice. He put these together and he looks at, what are we measuring when we measure visual acuity? Well, we're only looking at the fovea, a very small area in the eye. We still obviously measure visual acuity. It tells us a lot about what's going on with patients, but it's just a very small area. When we think about our 24-2 visual field, we're again only measuring 24-2, or we're measuring 24 degrees of the visual field, a very small area. And a pattern ERG is really only measuring a small area as well. We're not capturing a large area of what's going on with the eye. When we look at a full field ERG, we're measuring much more. And this probably matters a bit more in diabetic patients. But again, the RETeval ERG we're talking about tonight is very advantageous in patients with diabetes as well. And if you go to the LKC website, there's a great webinar that was recently done by Dr. Ferrucci. He really dives into the diabetic components of the RETeval that looks at the diabetic patient. I'm going to again focus more on glaucoma tonight, but you can just see the difference here when we go from visual acuity to the 24-2 to that full field ERG, how much more encompassing of the retina that it's covering. So this is probably one of the key pieces of the lecture tonight. And this is really looking at interpretation of a printout of the RETeval ERG. It's very straightforward. It color codes it in green, yellow, and red. But I think it's important to understand what we're looking at here and understand what the colors really mean. If you have a slow implicit time, that's the possibility or an indication of retinal ganglion cell stress. Doesn't mean there's damage yet. It means that those cells are stressed out. That would be early in the disease process. It's something that I really care about in a glaucoma suspect or an optic hypertensive patient, where maybe I haven't necessarily made the diagnosis. Maybe I haven't started treating the patient. Maybe I won't treat the patient, but I want to know what the stress level is on those particular cells. When you look at this, you're going to see in a printout, it may flag it as 30%. It may flag it as 94%. 94% may still fall within the green. And I think of that kind of like green disease. If I see 94% on implicit time, that's still a pretty slow implicit time. Even though it's green, that's going to concern me a little bit. Unlike if it's down around 30%, 33%, I'm not worried about that. If it flags it yellow or red, then of course that's a slow implicit time. That means there's stress to those retinal ganglion cells. The amplitude looks at cellular damage. So the amplitude to me is more important in a patient that I've already diagnosed with glaucoma. I'll still care about the implicit time because the implicit time is looking at maybe cells that have not been damaged yet, but the amplitude is going to look at cellular damage and an indication of more cellular damage to an area that's already been damaged. And so the amplitude, again, if it's down close to that 5% mark or it's a low amplitude, that's going to be more concerning to me than if it's up around 100% or a high amplitude, which means there's not an indication of a lot of cellular damage that's occurring. So again, I'll piece this all together for you when we get into a case here shortly. We know, again, I kind of reviewed the anatomy of the retinal ganglion cells. We measure the RNFL, which is the ganglion cell axons, the body of the retinal ganglion cells in the ganglion cell layer. And then we have the interplexiform layer, which is the dendrites of the retinal ganglion cells. And we can see this beautiful printout here showing really what's happening with the different retinal ganglion cells and how they kind of go around or function on the eye. There is studies that are shown, and there's still talk around this, that is this true or not? I think there's plenty of evidence to support that prior to this irreversible cell death, these retinal ganglion cells are compromised. And if we catch it early enough, that we may be able to reverse things. Now, if there's already been significant visual field damage, there's already been significant RNFL loss, significant ganglion cell loss, it's going to be much harder, obviously, to reverse that. We're probably not going to reverse someone that has a nasal step with significant RNFL loss. But if we catch it early and we make a decision that there's a bunch of other risk involved, we may want to treat these patients, lower their intraocular pressure, and try to protect the retinal ganglion cells as much as possible. So this is really where ERG comes into play, catching the disease process early, treating it if we deem that there's enough risk there to make sure that we're managing our patients early on. And this was another study, this was published in 2013, looking at lowering intraocular pressure and the help to those retinal ganglion cells. So here's a printout. Now this would be a situation where it's normal, and where I want to draw your attention to is the bottom portion of the printout, the photopic negative response. Again, this is for our glaucomatous patient population. When you look at this particular printout, there's a lot of numbers, there's a lot of green, and there's a lot of red and yellow as well. And all these numbers can be very confusing. Really, the biggest thing that you want to look at when you start utilizing this is, number one, were the sensors lined up correctly? And you can see the image of the patient there in front of you. And there is indicators or lines on these sensors that kind of tell you where you should line it up. And you can see this is perfectly lined up right down the center of the pupil. And the edge of the electrode is right where it should be as well, or the sensor strip is where it should be as well. So you know that it's a perfect lined up, accurate measurement. The other way you can tell if it's accurate is you look at kind of the wave score there, and you're making sure you're getting what you saw at the beginning. You're getting that accurate A wave, you're getting that accurate B wave, and you're getting that photopic negative response, which is marked with the red arrow there. Now you move down to the printout itself, or those bottom numbers. What you're seeing there is the MS is the implicit time, the UV there, or that symbol there, is your amplitude, and then the W ratio. I really care about the implicit time and the amplitude. You can see in this particular patient, they're at 36% on their implicit time. That's a very good implicit time. And they're at 48% on the amplitude. Very good as well. The retinal ganglion cells are not under a lot of stress here, and there's no indication of cellular damage when you look at this patient in both the right and the left eye. Look at the left eye, it's at 53%, a good implicit time, and again, 36% on that amplitude. Again, telling us this patient has no cellular stress going on and no cellular damage that's occurred either. Now, when you look at a patient that does have some damage, again, we're looking at the implicit time, we're looking at the amplitude. If we look at that right eye, to my point earlier, it's at 90%. It still falls within green, but it's getting very close to falling into the yellow. To me, when I see a 90% on that implicit time, those retinal ganglion cells are under stress. That's a little bit concerning. I'm going to look at the other pieces to the puzzle in this patient. What's their IOP? What does the OCT look like? What's their corneal thickness? Where's their visual field at? All of those things, but there's stress occurring to those retinal ganglion cells. And then if we look at the amplitude, you can see that being at 1%. There's probably already some cellular damage that's occurred. I'm going to go ahead and look at that OCT. I'm going to look at the visual field. Does that all kind of jive and match up? You look at the left eye, 34% for the implicit time. The amplitude looks really good. The left eye, not as concerning to me. And that would be a situation where, again, you look at those technologies. Does that match up? Does it make sense that the right eye is under a lot of stress? There could be damage to the left eye, not so much. So using that puzzle to piece it all together. So now I'm going to get into the fun stuff. You know, for me, cases are the best part of learning about technologies. I love glaucoma. I love the nerdiness that comes around it. I love the artful piece of glaucoma. I think it's a very artful eye disease. I mentioned earlier that you have all these different puzzle pieces that you got to kind of piece together in order to manage and diagnose it. So with this particular case, we term it funky optic nerve head with borderline IOPs, and you'll see why here in a second. So this was a patient of mine, 67-year-old Caucasian male, long-standing history of primary open-angle glaucoma. I've been following him for quite some time, and he presented for a recheck on 8/24 of 2021. I started to utilize the RETeval around this particular time, a little earlier in this, but this case really fit well because this was a gentleman that, as you'll see here in a minute, I really struggled with analyzing his OCTs. His visual fields were tough to analyze as well. mainly because of what you're going to see here was around his optic nerve head. So his vision was 20/20 in the right eye, about 20/30 plus in the left eye. He had had cataract surgery. We had done a MIGS procedure on him as well. He'd had a YEG as well. He was best corrected to 20/20 in both eyes. He just elected not to wear glasses quite often. He felt comfortable with his vision at this point in time. He's on 2 medication. He was on generic latanoprost as well as generic timolol, once at night and then once in the morning. And when you look at his intraocular pressure, I'm a big fan of corneal hysteresis. I'm a big fan of IOPCC. There's a lot of data to support these measurements. This is done by an instrument called the Ocular Response Analyzer. I was pretty happy with his intraocular pressure when you look at where his Tmax pressure was. Tmax pressure of 22 in the right eye, 23 in the left eye. When I'm lowering intraocular pressure, especially in a patient with what you see here in a little bit, I want at least a 30% reduction. I would argue in this patient that we probably need a little bit more, maybe about a 35% reduction, because he has a little bit more advanced glaucoma, as you'll see with the OCT and visual field here. He does have thin corneas. We know from the OATS study, and this isn't a case for OATS because this gentleman was already diagnosed with glaucoma, but if you have an ocular hypertensive patient, we know from the OATS study that if they have a 555 micron cornea or less, they're at a much higher risk for converting from ocular hypertension to glaucoma. If they're above 588, they have a much lower risk of converting from ocular hypertension to glaucoma. So those are the 2 numbers you want to keep in mind. Don't adjust IOP based on corneal thickness. Assess risk with corneal thickness. So less than or equal to 555, higher risk of converting. 588 or above, lower risk of converting. This particular patient also had a high corneal hysteresis in his right eye and a borderline or almost normal hysteresis in the left eye. Low corneal hysteresis, 8 or below, is the risk factor for me. Plenty of studies showing that as well as a risk for progression of glaucoma, as well as conversion to glaucoma as well. So for this particular case, I liked seeing his corneal hysteresis being on the high side, or at least the borderline side. Gonioscopy was open to ciliary body with no pigment, and then additional testing you're going to see next. Here was his fundus photos. So he had a 0.60 cup to disc ratio, and you could tell already that his optic nerve heads are very hard to assess. Now this is an image, hard to assess on an image, but even through the slit lamp dilated exam, it was very hard to assess his optic nerve heads. Left eye as well, I cupped the disc around a 0.65, all this peripapillar atrophy, and then he had epiretinal membranes as well. So 2 things occurring here that make it hard to assess. Number 1, the epiretinal membranes are going to throw off my ganglion cell analysis. They're going to throw off anything that I can assess in that regards. Now, they're not going to throw off an ERG, but they will throw off the ganglion cell analysis with the OCT. The other thing that throws off the OCT is his optic nerve head appearance. He's got a small optic nerve head. He's got all this peripapillar atrophy, and you're going to see with the OCT here in a second, there's just absolutely no way that I could really trust it in this particular patient. Here's what his OCT looked like. You can look at the macular thickness there. You can see the epiretinal membrane really throwing that off, making it very difficult to assess. You can also see on the OCT here, right and left eye, when you look at the corneal thinning, if you look at the Tisnet curve, really not a very reliable Tisnet curve. This gentleman has some RNFL thinning, but typically in more advanced glaucoma, you will see nasal thinning, but in earlier glaucoma, you don't typically see nasal thinning. There's absolutely no way you can trust this particular OCT in the right or the left because he has a ton of nasal thinning that really didn't add up to his clinical picture. And so the things I'm taking away so far with this patient is I feel good about where I have his IOP. I at least got that down to about a 30% reduction. He's got high risk of his thin corneas. He has less risk because he had a little higher corneal hysteresis, so I feel decent about that. I don't love my OCTs because I can't trust them. It's just impossible to get accuracy with them. And then here's his visual fields over time. He wasn't a great test taker. There is some reliability here in the right eye, and he did okay. And it doesn't appear that he's progressing on his visual field. If you look at the mean deviation and you look at the pattern standard deviation, it did jump up a bit in August of 2021. The pattern standard deviation did, but overall, it looks variable. It's jumping back and forth. You can see in 2020, the pattern standard deviation matched with 2021, but if you look at March of 2019, it really doesn't match. He does appear to be maybe having this kind of inferior arcuate defect forming. Maybe there's an early nasal step there, but again, I'm not overly confident because his OCT is really not accurate. And then you look at his left eye, a very repeatable defect here. So I'm not arguing that he doesn't have glaucoma. And I apologize, there's a typo on the visual field. This is his right visual field. As you can see, OD, even though the visual field says OS up there, this is right visual field. And then this is his left visual field here. Again, no argument that there's glaucoma here. So this is a patient that I said, I'm going to run an ERG on because I need to feel a bit more confident. Doesn't mean I'm going to change his treatment. I like where his IOP is, but I need something to build my confidence a bit. And a guy that has fairly advanced glaucoma in his left eye and also does have some glaucoma in his right eye, and the OCT is really not helpful. So here's his ERG printout. And what made me feel very comfortable about this particular patient, if you look at his right eye and you look at the implicit time, 44%. In his left eye, 69%. Approaching, getting closer to 95%, but the cell's really not under a lot of stress. What that tells me is we know he already has damage. He has visual field defects. So the amplitude to me in this particular case isn't as important as the implicit time. I really care about the implicit time because I want to know the healthy cells, the healthy retinal ganglion cells, how much stress are they under? Well, in his particular case, it all fell within the green, fell pretty normal in the right, still pretty normal in the left. So his healthy retinal ganglion cells are not under a lot of stress. Makes me sleep a little bit better. Still going to watch this patient very closely. Still going to monitor his visual fields. Still going to monitor his intraocular pressure. But I'm confident in telling him that the healthy part of his eye, the healthy retinal ganglion cells, are likely not being stressed out. And let's hold tight on doing any other treatment options. We would expect to see the amplitude down a bit because he does have fairly significant visual field defects already, and he definitely does have glaucoma. Case number 2. This was a patient that was referred to me with significant cataracts, and the referring optometrist just said, I think maybe they have glaucoma. I'm not sure if they have glaucoma. Would really love your opinion on this. I definitely know that they need their cataracts taken out. And so patient with cataracts, questionable glaucoma. 69-year-old Caucasian female. Patient's main complaint, what's been getting harder to see, they're sometimes wearing their glasses, sometimes not wearing their glasses. They're noticing more glare at night. You can see the visual acuity here. Best corrected only to 20/40 in the right and left eye. This patient brightness test acuity down to around 2100, 2400. Previous eye history, labeled them as a glaucoma suspect in both eyes, mainly because of my colleague in the community that labeled them as well. The current medications, no allergies to anything. And then slit lamp exam, definitely showing significant cataracts in both eyes, some epithelial basement membrane dystrophy as well. And then when we look at the interocular pressure here, the IOPCC, the corneal compensated one, what I care about, 18 in both eyes. Corneal hysteresis elevated, which is good, 12.8, 13.1. That makes me feel a little bit better already. Corneas are on the thin side though, so that's a little bit more risk, but the patient doesn't have elevated intraocular pressure. You can see the rest of the exam here, a 0.5 cup to disc ratio in both eyes, and the macula was normal as well. When we look at the OCT, this makes me feel pretty good about this particular patient. You can see the OCT average RNFL about 97 in the right eye, about 99 in the left eye for a patient that is 69 years old. That makes me feel pretty comfortable. But the main reason that the referring optometrist or the colleague in my community that was concerned was these visual fields definitely look a bit glaucomatous. When you look at the left visual field and you look at the right visual field, which I put in front of you here, you can ignore the headline there with visual field OS. We have both of them here for you. You can see that there is almost what appears to be kind of a superior arcuate defect. On the right eye, the same thing. So I could see why my colleague in the community said, boy, I'm a little bit worried about glaucoma, but it doesn't really match up with the OCT, and it doesn't match up with any of the other clinical picture. Now, one thing that jumped out at me on this is, could this be something neurological? It is something that crossed my mind, and it is something that I would consider getting images if there was other issues going on. I would consider an MRI possibly in this particular patient. We ultimately did not do that, and I'll explain that here in a second why. The next step we did is I said, let's go ahead and get an ERG. Yes, there's a dense cataract there, but we don't have to worry about it with the RETeval. It can go right through that medial opacity. And what we're seeing here is a very healthy ERG. You can see the implicit time being down around 20%, the amplitude being at 35%, so very normal as well. You can see the left eye, the implicit time being at 39%, the amplitude being at 46%, telling me two things. Number one, there's no stress to the retinal ganglion cells. Number two, there's no damage to the retinal ganglion cells. This really matches with what the OCT showed us, but didn't match with what the visual field showed. Ultimately, what we decided to do is let's do cataract surgery. We're not going to do any type of MIGS procedure. We're not going to go ahead and start any therapy. I don't think this patient has glaucoma. And the ERG made us more confident in regards to that. We eventually then repeated these particular visual fields after the cataract was out, and ultimately the defects essentially went away. There was a few scattered defects here and there, but the visual fields really just became inaccurate. When you think about the visual field here, though, you can't blame it on the media opacity because the total deviation and the pattern deviation are matching up very beautifully. And normally if I see this in a glaucoma patient, I'm thinking, boy, that very likely is glaucoma. Again, structure and function were not matching up in this particular situation. So the ERG was very helpful in building confidence, but also in telling me, get the cataract out and then we'll reassess the visual field. We did, it looked normal. We've moved on and we're monitoring this patient, and the referring colleague in the community is taking care of this patient at this point in time. So that's really just an overview of the glaucoma piece of things. And I'm going to wrap up just briefly with a couple of diabetic retinopathy slides. Again, I really wanted to focus on where it can fit in our glaucoma patient population. I've been very happy with it for a variety of situations, and those are two prime examples of where I will utilize ERG or the RETeval in my glaucoma patient population. Again, I don't run it on every single glaucoma patient. I utilize it like any other diagnostic tool. There are certain patients where I like to use it. Those were just two examples of that. There is a case for it in diabetic retinopathy as well. The printout is a bit different. And again, please go to the LKC website, watch Dr. Ferrucci. He's an expert in this. He'll give you a great overview of really where this can be utilized in diabetic retinopathy. But ERG has been shown over and over again to be very useful in patients with diabetic retinopathy. And as that increase in disease severity occurs, the amplitude begins to decline. And you can see it here in this particular printout here, going from NDR to mild non-proliferative diabetic retinopathy to moderate non-proliferative diabetic retinopathy, and so on and so forth. So you can just see how that amplitude is changing. And really what the RETeval does is it has this diabetic retinopathy assessment protocol, which really takes into account 4 different things. It looks at implicit time, just like in glaucoma. Longer times increase the score. So if the implicit time is longer, that's not good. The amplitude, the smaller the amplitude increases the score. It then takes into account the pupillary response. So a less reactive pupil will increase the score, and then an age. And so this has all been utilized and normative data has been combined, and the RETeval then spits out a particular number for you, and it's on the printout and very easy to find. I like to think of it, like some of the data around smoking. Smokers are at 11 times increase for developing lung cancer. So if you smoked in your life, you're at an 11 times increase to developing lung cancer, but that doesn't mean every smoker develops lung cancer. Really what you're getting here with the RET-DR assessment protocol is that last bullet point there. If the DR score is 23.4 or more, there's an 11-time increased risk of needing surgical intervention within 3 years, or ocular intervention. I shouldn't say surgical, but ocular intervention for that patient's diabetes. So that doesn't mean if they score a 25 that you're necessarily going to do anything, but you definitely are going to watch that patient a lot closer. And so that key number there is 23.4 or greater. They have a much higher risk of needing ocular intervention within 3 years. Here's that printout, very simple, easy to read. You can see the DR score here being 24.8, so outside that normal limit. And again, as long as it's an accurate measurement and an accurate test, that would tell you that you may want to intervene earlier, you may want to watch them closer, you may want to bring them back more often. So it definitely has some utilization for our diabetic patients. It definitely has utilization for our glaucoma patients as well. So in summary, ERG is a powerful tool for the medical optometrist. We can definitely use this for our glaucoma patient population. We can definitely use this for our diabetic retinopathy patient population. It's detecting cellular stress with those implicit times. It's also looking at damage to the retinal ganglion cells. It really helps us make better decisions for our patients, especially when there's conflicts between what's the OCT telling us, what's the visual field telling us. Maybe one's accurate, one's not. The ERG can complement that, and we can use all the different puzzle pieces to help diagnose and manage our glaucoma patients. It helps us to make better decisions from a follow-up standpoint. Doesn't necessarily mean we're going to treat every patient that has a low implicit time, or has a bad amplitude, just means we may watch them closer. We may bring them back more often. And I do believe it is a critical piece to our diagnostic puzzle. I mentioned all those puzzle pieces earlier. The OCT matters, the visual field matters, corneal thickness matters, corneal hysteresis matters, family history matters, IOP matters. But I think this is a piece too that you can utilize in a variety of different situations. And I hope those two cases kind of help you think about that for your glaucoma patient population and where you could utilize it in your practice. There's a code for it. There's a CPT code 92273. You can see the average reimbursement for this particular technology. To be very clear and transparent, in our practice, we've just elected not to bill for it. I believe strongly enough in it. We have one in our practice because I've liked to utilize it in a variety of different ways. I'm not telling you you shouldn't do that. You know, with the diabetic code, you know, you do get reimbursed quite nicely for that. Glaucoma is a little bit more tricky. For me, I just feel like it's a useful enough tool that we're going to utilize it in our practice when we need it. And we just do not bill for it. We don't go through that. Again, that's me. That's my practice. I'm not urging you to do that. I would urge you to dig into this though. There is a CPT code when you ultimately have this particular device in your practice. And so with that said, it's about 7:45 here Central Time. And so I want to go ahead and wrap up, but I can take any questions if you have any. I really want to thank everyone for taking your time tonight away from, you know, family, friends, significant others to spend it with me. I know it's never easy after a long day in clinic that you come and have to listen to a webinar, but I sure appreciate your guys' time and for all of you that did show up. But I can stick around for a few questions if there are any.
Dr. Schweitzer, there was a question that came in that said, can you go into a little more in depth of looking at the W ratio versus the other parameters when determining damage progression of glaucoma?
Yeah, I mean, from a standpoint, the W ratio to me is kind of just taking all of it into account. So if you have a score above 1, then that is a good score on the W ratio. If it's below 1, that's an indicator of something is probably not good or accurate. Now, for me personally, I pay attention to implicit time and I pay attention to amplitude. I'll look at the W ratio, but the two most important parameters to me is what's happening on implicit time and what's happening with the amplitude. And those are my first and second things I look at. And the W ratio is there and I'll peek at it, but I care what's happening with implicit time and amplitude. So in other words, I'm steering you to, when you're reading your printouts, focus on those two things. It's nice to have that W ratio there, but focus on those two things. The most important things are those two things.
Right. I don't see any other questions. Does anybody have anything else that they would want to ask before we sign off for the evening? One question just came in, says, can you see improved results with treatment?
Yeah, that's a great question. My personal experience has been I have not seen that. There's studies, and I showed one of those on the slide deck, and I believe you'll be able to see this in a recording again, that they have showed that. So there are a few studies that have showed that. For me, I utilize it more to look at stress, and then I will utilize it to follow progression. And what I mean by that, the amplitude can be very helpful for that. So that patient I showed you earlier that we know has glaucoma already, the first patient, he has glaucoma. There's no doubt about it. I don't believe he doesn't, but I have an amplitude score. What I can do is I'll still run his visual fields. I know his OCTs are very hard to follow. I'll look for progression on the visual field, but I'll monitor the amplitude to see if that's changing. If the amplitude continually gets worse on visit to visit over time, that's an indicator to me that that patient is progressing. So you can utilize that to monitor progression as well.
Make sure I'm not missing anything else. I don't see anything else. I think we're good.
Excellent.
All right.
Well, thanks everyone. I really appreciate the time. Gail, thank you.
You're welcome. Thanks, Dr. Schweitzer, for enlightening everybody and continuing to educate about the RETeval and how it can be used to help diagnose and monitor patients with glaucoma. Thanks, everyone, for attending. Have a good night.